Hi, I'm Professor Mehmet Engin. Today's seminar title is Thermomammography for Evaluation of Chemotherapy Response in Breast Carcinoma. Firstly, I would like to express that the seminar is based on the related original research article. Now, the framework, the seminar, firstly, introduction and motivation, patients and methods, procedures for thermography measurements, statistical analysis, and results, including the following subtitles: patients and tumor characteristics, clinical and pathological assessment of tumor response, thermomammography assessment of tumor response, and finally, discussion and conclusions. Now, introduction and motivation. Infrared imaging of the breast is commonly known as breast thermography, painless examination and non-invasive modality which mainly measures the temperature of the breast and does not expose the subjects to toxic ionization radiation and test a subtle change of physiological response of the breast. Thermographic imaging has already been clinically used as a screening and diagnosis tool to detect the breast cancer, where high blood flow and metabolic activity due to high vascularity of the tumor is warmer than the surrounding normal functioning tissue. Thermographic or thermomammogram (TMG) imaging can examine both tumor growth and vasculature changes. Recently, breast thermograms are widely applied for the precise detection of breast cancer worldwide. Most of the patients diagnosed with advanced breast cancer undergo perioperative neoadjuvant chemotherapy (NACT). Patients with pathological complete response for the NACT are associated with longer disease-free survival. Unfortunately, between 8% and 20% of breast cancer patients will not benefit from NACT and will be treated without clinical or pathological response. Diagnostics methods to predict early response during therapy would help physicians to decide evidence-based changes and treatment strategies and potentially minimizing side effects and maximizing therapeutic outcome. At present, most commonly used assessments of response to NAST is by clinical examination alone with its subjective in nature. Many other methods that are in practice to monitor the NACT response include ultrasonography, mammography, and contrast-enhanced magnetic resonance imaging, MRI, magnetic resonance spectroscopy, and functional imaging technologies such as positron emission tomography. Mammography is currently the most efficient imaging method for detection of breast cancer with an accuracy of around 19% for screening. Although many treatment guidelines recommend mammography, the difficulty in assessing the tumor size is problematic when mammography is used for an application in chemotherapy response evaluation. Even some of the recent methods, including functional imaging technologies, require exogenous contrast agent that may be poorly tolerated by some patients and are formed at significant expense. Hence, practical limitations include preventing many of these methods from being applied in clinical practice for the use. This study aims to analyze the temperature variations for the response to NAST in locally advanced breast carcinoma to using thermal mammography by the following. First, whether thermography is useful to monitor the neoadjuvant therapy? Second, is there any possibility of using information obtained from thermography to predict the response to therapy? Third one, what is the prediction model or proposed prediction model? Now, patients and methods. This is a single-center prospective cross-sectional study. The study includes 19 consecutive locally advanced breast cancer patients who are undergoing NAST during the period from January 26th. Before the start of the study, signed informed consent was obtained from all patients whose breasts were imaged with minimum of 21-day interval up to minimum of 3 cycles of chemotherapy. All patients were also assessed clinically and sonomammographically. Figure 1 shows the correlation of sonomammographic report with the thermography results. Before every chemotherapy cycle and imaging sessions, data and grade histological subtype, size, and tumor response are per clinical assessment were recorded for all patients. Patients were categorized as follows. Complete response. Complete disappearance of all disease. Partial response denotes 30% reduction in the sum of the longest diameter of the target lesions. Stable disease condition. Change not meeting criteria for response of progressions. Progressions. More than 20% increase in the sum of the longest diameter of the target lesions. And last one, stable disease and progressive disease are considered as the no response to chemotherapy. Now, procedure for thermography techniques. Thermal images were taken using a medical device for breast imaging without involving any radiation or contact with the patient breast. The subject lay prone on the imaging bed during the procedures with the breast suspended through the opening in the top of the bed. Each breast was imaged individually. Infrared imaging began with a brief period of temperature status, after which a stream of cool air was circulated within the temperature conditioning chamber around the uncovered suspended breast. This system called dynamic rotational infrared imaging. Multiple infrared images were taken at 1 every 15 angle by the infrared camera, both before and after the cooling phase. After the first breast was imaged, the process was repeated for the contralateral breast. The entire session required approximately 15 to 20 minutes. Thermal images were acquired in the affected site and the other site. Now, statistical analysis. All baseline data, namely demographic or characteristics, and endpoint data are summarized with descriptive statistics, such as median and interquartile range, 25 to 75%. Normality violations for each parameters were checked using the Shapiro-Wilk test. It's categorized the final disease status as a categorical variable, that is, no response, partial response, or complete response. Non-parametric mean Whitney test, namely two-sided 19 95% confidence was used to calculate for statistical significant changes in thermography temperature in chemotherapy cycle 1, cycle 2, and cycle 3 between no response, partial response, and complete response. Statistical significance level of P less than 0.05 was used to assess statistical significance. Now, results. Firstly, patients and tumor characteristics. The clinical characteristics of the patients and their tumors are summarized in figure table 1. In this table, the median age of female patients was 50 years and 7 patients more normally menstruating. Patients had a different combination of neoadjuvant treatment plans. Of the 19 patients, 3 had tumor grade 1, 11 patients had tumor grade 2, and the rest, 4 patients, had tumor grade 3. The adjuvant treatment response is usually good for high-grade 2 or 3 tumors. However, in this study, only 2 patients had complete response. Estrogen progesterone receptor PR marker positive patients responded very low for neoadjuvant treatment. As expected, among 9 PR positive patients, 7 patients were failed to complete treatment responses. If human epidermal growth factor receptor 2, namely HER2 biomarker, is positive in histopathology, neoadjuvant treatment response is good. Even though 7 patients had HER2 neopositives, only 1 patient had complete response. Now, clinical and pathological assessment of tumor response. Reduction in tumor volume has been widely used as the standard criterion for treatment response evaluation among solid tumors, including a breast cancer. 3 types of pathological response pattern from the chemoresponsive group observed. Among the 19 patients, the tumor was undetectable at cycle 3 of treatment in 8 patients, and they were categorized as complete, as shown figure 2. Six patients had only 5 patients had poor response, and they are categorized no response group. These results are shown in figure 3 and figure 4 respectively. Now, thermomammogram assessment of tumor response. Overall, 19 patients' thermography details were collected of 3 cycles of neoadjuvant treatment to assess the potential of thermography in predicting early responses, the pre-cool, post-cool, and temperature difference before every cycle were analyzed. Median of pre-cool temperature difference for patients between no response and complete response didn't show statistically significant difference. However, median of post-spot temperature for patient in visit 1 is show statistically significant differences. The results is shown in table 2. Similarly, median of pre-cool temperature difference for patients between partial response and complete response didn't show statistically significant differences. However, median of post-spot temperature for patients in visit 1, visit 2, and visit 3 respectively didn't show statistically significant differences as shown in table 2. Median of post-spot temperature for patients with no response and partial response for visit 1, visit 2, and visit 3 didn't show statistically significant difference. Same results were also obtained for pre-cool temperature difference. That temperatures didn't show statistically significant differences for any visit, as shown in table 2. Discussion. In this study, the application of thermographic infrared imaging techniques to detect the response of NASD in carcinoma breast tumor has been demonstrated. It is shown that the utility of thermographic infrared imaging for the response to neoadjuvant chemotherapies to breast cancer. Infrared imaging procedure is a physiological test that measures the subtle physiological changes in the body, such as cancer. These conditions are commonly related with local hyperthermia, vasodilations, hypermetabolism, hyperperfusions, and hypervascularizations, which generate a high temperature heat source. Hence, the thermographic imaging technique can be applied to non-invasively monitor the breast tissue response expected to have triggered by anti-cancer agents administered in chemotherapy to breast cancer patients. It is shown that this monitoring is possible in the first 3 cycles after treatment, a period in which the patient does not show a significant clinical physical response to treatment. This will bring significant benefits since monitoring can be carried out in the treatment over the entire treatment procedure rather than having not benefited for the treatments. Among all the methods, there was a trend that the post-cool temperature was educated that this temperature information can be used to monitoring the therapy. It is assumed that the combined use of pre-cool and post-cool temperature modalities may provide valuable insight to predict treatment response better than separate modality alone. However, results confirm that the post-cool temperature can be used for accurate measurement of the treatment response. Hence, assessment of response to chemotherapy in the breast carcinoma during neoadjuvant setting can be monitored using thermomammography. Conclusion of the seminar. This preliminary study suggests that the thermography infrared technique has a potential for monitoring neoadjuvant treatment response in the breast cancer patients. In addition, Post-school temperature measurements may offer an early indication of the physiological changes happening in the breast tissue in response to neoadjuvant therapy. These findings, combined with the improved thermography infrared technique, support further for monitoring breast cancer treatment response. Thank you. See you again. Bye.